posteriorly. As we move posteriorly, we stop at an area where we can see the anterior and middle scalene, and in between them, the nerve roots, C5, 6, and C7. This is the drawing. This is exactly. This is the typical traffic signal sign. Okay, there are certain adverse effects associated with interscalene law. Always remember, as we move, as we are medial to the on the most medial part, there are more adverse effects or complications. As you move laterally or distally, the complications and adverse effects are low. There can be accidental vascular injection of the local anesthetic, and the patient will present with seizures, cardiac toxicity. Recurrent laryngeal nerve can be blocked, cervical sympathetic blockage can accidentally occur with hoarseness, presentation of the patient. Stellate ganglion can be blocked, the patient will present with Horner syndrome. A phrenic nerve can be blocked frequently, and a hemidiaphragmatic paralysis can occur. The high epidural total spinal subdural injection, the transient neuropathies, hematoma, pneumothorax, venous embolism, and subcutaneous emphysema, pneumomediastin. These are all the adverse events. To avoid the phrenic nerve, what we can do, we can reduce the local anesthetic volume, and we will give the local anesthetic close to the C7 level, or we can go for an alternative, the supraclavicular power. And there is the sparing of the inferior trunk. This is another adverse effect. So it can be, if we give the block more distally, so it can be addressed. There are contraindications. Contralateral, if the patient is having contralateral phrenic nerve block already, or the patient is having a contralateral recurrent laryngeal block, so interscalene block on that side is contraindicated. Now coming to the supraclavicular brachial plexus block. As we are moving from one to another block, always remember we are moving from this part of the neck down. Now we are at above the clavicle. We will go down below the clavicle or infra, and then the axillary clavicle. Supraclavicular brachial plexus block. It is indicated for surgeries at arm, elbow, forearm, hand surgeries. Its equipment is the same except for the volume. The volume is 20 to 25 local anesthetic, and the needle size is same, 50 millimeter or 5 centimeter, 22 gauge short pivot insulated stimulating needle. Ergonomics. Patient is lying supine at 30 degree, 45 degree, heads up, and the head is turned slightly contralateral. The operator stands on the same side of the patient as the block with ultrasound machine on the opposite side. Always remember, for blocks, there is a sequence: the performer, the probe, then the patient, and then the ultrasound machine. They all should be in this sequence and in a single line. As we can see in this picture, this is the performer, this is the probe, this is the patient, and this is the ultrasound machine. So he can easily control everything. The most common complication with the supraclavicular brachial plexus block is the pneumothorax, subclavian arterial puncture, the ipsilateral hemidiaphragmatic paralysis. As we keep the probe in at the supraclavicular area, we are going, first of all, focus on this colorful illustration. We are going to see all these structures. We will see the subclavian artery, and lateral to that, you will see the first strip down, and above that, you will see a brachial plexus trunks. And this is the pleura. If we go, this is the sonor anatomical illustration, in which we can see this is the medial part, this is the lateral part. Subclavian artery, this is the brachial plexus trunks, this is the rib, and this is the lung. Preferably the needle should be inserted only when the rib is visible more instead of the pleura. So that if the needle hits something, it should be the rib, not the pleura. Again, in this picture, we can see this is the medial part, this is the lateral part, this is anatomical illustration. This is the subclavian artery and all these. This is the brachial plexus, and this is the rib, as can be seen here. This is the first rib, this is the pleura, and this is the needle is coming from this side. This is subclavian artery, and these are the trunks. This is this blue shaded area is the drug injected part, these trunks, further this fascia is divided into two, the upper trunk and the middle and inferior trunk. So the injection is given at two locations, 10 ml at the upper trunk and 10 ml separately for the middle and inferior trunk. And remember this corner pocket, the most distal part of the inferior trunk. So whenever we are going to give a block, so we have to take the needle down here for this corner pocket, and we will start depositing drug in this. It's going to cover both the inferior and middle trunks. Again, this is subclavian artery, the medial part, the lateral part, and this is the brachial plexus. This is the pleura. The first strip, this is again drug given, shaded part. Okay. This is again another illustration, and we can see the needle coming from this this area. This is the lateral part, this is the medial, and the needle is coming. You see the rib is more visible and the pleura is the side, and this is the best visualization. So if the needle hits something down to reach the corner pocket, it should be the rib, not the pleura. So it's safe here. Okay, these are the side effects that include the phrenic nerve block, the Horner syndrome, recurrent laryngeal nerve block, inadvertent arterial puncture, the nerve injury, pneumothorax, local anesthetic, systemic toxicity, infection, and hematoma. Now coming to the infraclavicular brachial plexus block. Now we are coming down to the cords level. So at interscalene, the nerve roots at supraclavicular level, the trunks of the brachial plexus, and at infraclavicular level, the cords of the brachial plexus. So infraclavicular brachial plexus is indicated in surgeries at shoulder, forearm, and wrist and hand. Its advantages are it gives us a comprehensive upper extremity anesthesia, it has a lower incidence of tourniquet pain, it's a preferable site for catheter insertion because the catheter gets fixed or grasped well between the major and minor muscle, and it has a higher success rate than the axillary block and is less likely to spare the musculocutaneous nerve, which you usually see in the axillary brachial plexus block. It's an alternative approach. It's an alternative approach to anesthetizing the brachial plexus, especially in patients with limited mobility of the body. It's preferred in patients unable to abduct the ipsilateral arm in order to perform an axillary brachial plexus block. This is the equipment. In this, a little long lesion, 8 to 10 centimeter or 80 to 100 millimeter, 22 gauge insulated stimulating nerve block needle, and 20 to 40 ml of local anesthetic drug is required. It has three approaches. One is the classic approach that we call the coracoid approach. Second is the clavicular approach, and third is a new technique, the raptor approach. First, coming to the classic approach, and this, if we note, this is the clavicle, and the probe is placed below the clavicle in a parasagittal plane, and the needle with a quite higher angle moves in an inclined position. This is how. This is the cadaveric cut section, paramedian sagittal plane at the level of coracoid process, and the injection of local anesthetic should take place below the fascia of the pectoralis minor muscle. We will see the pec major muscle, then the pec minor muscle, and below the pec minor muscle is a fascia. We have to cross that fascia to reach the cords. If we give drug above the fascia, so the cords are not going to allow. What we are going to see, this is a colorful illustration. The pec major muscle, if we keep the probe here at infraclavicular level in the parasagittal plane, we are going to see these structures: pectoralis major muscle, the minor muscle, and axillary artery. Around the axillary artery will be the three cords: the lateral cord on the lateral side, medial cord on the medial side, and inferior to the axillary artery visualized on ultrasound is the posterior cord. The medial and posterior cord again are in the same fascia, and the lateral cord we need to give drugs separately. And most medially to these will be the axillary vein. This is the anatomical illustration in which we can see the pectoralis major muscle, the pectoralis minor muscle, the axillary artery, axillary vein. This is the lateral side, this is the medial side. We will come from the safe side, the lateral to medial approach. These are the lateral cord, the posterior and the medial cord, and this is the fascia below the pectoralis minor muscle. This transducer is kept in the medial infraclavicular fossa parallel next to the clavicle to identify the axillary artery, and then the brachial plexus cords are identified as hypertrophic oval structures arranged around the axillary artery. In case if we do not identify the cords, it's fine, we can give drug at the position of the cord around the axillary artery. The needle is inserted from lateral to medial direction. Now coming to another second approach, the costoclavicular approach. It is different from the first one in the sense that the probe, instead of keeping below the clavicle in a parasagittal plane, the probe is placed horizontally or parallel to the clavicle. Now note down here, this is clavicle and the probe is positioned parallel to the clavicle. If we keep the probe in this position, we are going to see this colorful illustration. The axillary artery, the axillary vein, and lateral to the axillary artery will be all the cords in the form of a bunch of threads. Now, so anatomically, if you look here, first name, pectoralis major muscle, the subclavius, the axillary artery, vein, and lateral to the axillary artery will be all the cords. Now here they are not positioned around the axillary artery. They are like in a single bunch. This, the lateral, medial, and posterior. The raptor approach. This is raptor means the retroclavicular approach to the infraclavicular region. In this the needle position, if we see needle is approached above the behind the clavicle, so that the angle of the needle is reduced because the waves of ultrasound are reflected. If they are reflected back to the ultrasound transducer or probe, so any structure that will be visualized well. But if they are reflecting away, so we are going to miss the structure. If this is a probe, the needle is coming this way, so we are going to visualize this needle very well instead of giving it any acute angle. So that's when this raptor approach was devised. This is the classic, the first approach. And now look here, above, behind the clavicle, the needle is approached to reduce the angle. It's almost parallel to the probe. And in plane position, it's moved so that the needle is visualized completely. Again, in this we can see two needles. This is the classic approach and this is the raptor approach to reach the cords of the brachial plexus. This is the positioning. Head of the patient, head of the bed is elevated, head turned contralaterally, the arm is adducted, and there is a bump created under the scapula. There are drawbacks. There is a leap of faith when passing through the shed of clavicle, because at that specific point when the needle is moving below the clavicle, we are not going to see the tip of needle for that very short time, and that can cause potential trauma to the structures. Now coming to the axillary brachial plexus block, as you move down the cords, the brachial plexus transforms into branches, terminal branches. Axillary brachial plexus block is indicated in surgeries at elbow, forearm, wrist, and hand. Its advantages are it's relatively simple to perform. It's associated with a lower risk of complications compared with the interscalene, like the spinal cord or vertebral artery puncture, the supraclavicular block complication like pneumothorax, and it's a preferred choice in clinical scenarios in which access to the upper part of the brachial plexus is difficult or impossible. For example, local infection, burns, skin dwelling between a skeletal. The equipment is the same, but the needle size is again reduced. 50 mm or 5 cm 22 gauge short bevel insulated needle, and the local anesthetic volume is 15 to 20 ml. This is the axillary crease in which we keep the probe, and this is an in-plane approach to reach the structures. If we see here, this is the cadaveric cut section. This is the lateral part, and this is the medial part. This is the axillary artery in an axillary in a brachial plexus fascia, in which it is surrounded by the nerves. Above it will be the median nerve. Medial to the axillary artery will be found ulnar nerve, and below or posterior to it will be the radial nerve. And lateral to it in the fascia of the brachialis muscle, musculocutnaeous nerve is found. Now, if we note down here in the sort of anatomical picture, illustration. This is the fascia, the triangular fascia, which is all the 5 structures: axillary artery, axillary vein, and the 3 nerves: the median nerve, the ulnar nerve here, and the radial nerve, posterior or below the axillary artery. And lateral to it is the musculocutaneous nerve. This is again a colorful illustration in which we can see the axillary artery, the nerves, axillary vein, and the musculocutaneous laterally. This is again how the drug is injected. In this fascia, around the axillary artery, drug is given in targeted area, and then separately to block the lateral part of the forearm, musculocutaneous nerve is blocked. Okay, this is the axillary artery. This is the most common position. The positions can be changed in different individuals, but this is the most common position of the nerves around the axillary artery in 64.7%. Median nerve is at 11, ulnar at 2 o'clock, radial at 5 o'clock. In musculocutaneous separately. Okay. These are the indications, advantages already discussed. And for the interscalene, the brachial plexus, the disadvantages discussed. Supraclavicular has a potential for pneumothorax, and for infraclavicular, there is a deeper block is required and great discomfort during block aspect and requires more expert. For axillary brachial plexus, there can be hematoma in post-block and local discomfort, and for discoloration, relatively common, and it can be a site of in the site of injection can be tender. These are the complications. As we see, there is a long list of complications at the most medial part of the brachial plexus. But as you move distally to the axillary location, the complications are reduced. The nerve injury, axillary hematoma, and seizures. These are the contraindications. They are common for all the blocks. The patient refusal, local anesthetic, allergic, suspected infection, immediate trajectory, and patient on anticoagulant. And relative contraindications like a coagulopathy, systemic infection, chest deformities, short neck, dislocation of fracture of clavicle, and thick pectoral lesion, especially if you are trying a rapid approach. Thank you.